Speaking of fear and being afraid of things to do, I think that one of the most challenging things that we as urologists are asked to do is taking care of consequences, of complications of radiation treatment. So this is how I'm going to structure this lecture. It's going to be, I hope to rush through it. Why I'm going to cover is why LUTs, what is the correlation between LUTs and radiation treatment, how big is the problem, how we should manage, and how we can prevent. So why do we have LUTs after radiation treatment? This is a very known cascade of events of basically anything that can trigger a neuroinflammation and ischemia in the lower urinary tract. And this is exactly what radiation is doing. That's why we have urgency. We have a lot of these storage phase symptoms, urgency, frequency, nocturia. Very similar to the one, ischemia, done by us, by surgeons. The only difference, the big difference is in timing. It's very acute surgically. You cut the vein, you cut the vessels, you cut the nerves, you have an acute manifestation of the problems, or you burn them, and everything appears a little bit later, up to 5 years later. So keep in mind this when you are following this patient. What do we know from the natural history of radiation and LUTs is that they need time to cause symptoms, and it's dose dependent. The more radiation, the higher the chance of having problems with it. And as you can see here, this goes up to a year, up to 5 years after the radiation treatment, you might have some significant changes in the lower urinary tract. Does it change if you do it earlier or late? No difference. So it's not the timing when the radiation is done, but the amount of the radiation is given. But what you can see here is that the more you wait, the more you go from functional changes in the lower urinary tract to morphological changes, specifically the stricture. And the bladder, the post-radiation bladder neck stricture is one of the most challenging things that we can do. And I'm pretty sure in this digging holes into the bladder neck with the laser is not going to work very well. Another potential issue, and this is one of the reasons why a lot of patients are actually prefer to go to radiation rather than surgery, is that the myth that they will not get any ED after the treatment. The only thing is going to change is the timing of the ED. As you can see here, up to 1 to 3 years after the radiation treatment, the incidence of erectile dysfunction is exactly the same if compared to surgery, radical surgery. How big is the problem? We spend a lot of money to take care of these patients. Just think about the, we call these ancillary symptoms that are related with radiation treatment. The cost of the side effects of nocturia, like falls, fractures, loss of productivity. It's very expensive. And those are all important things when we are counseling our patients for what treatment they should go. So how to manage this difficult topic? As you can see here, and I mix a little bit male and female, usually the consequences and the reasons why you have functional issues in the lower urinary tract is not only induced by radiation. It's multifactorial. You have radiation. On top of this, the patient might have chemotherapy. On top of this, the patient might develop or might need some surgery. So all these things together are responsible for very important, clinically significant lower urinary tract symptoms like stress urinary incontinence, urgency urinary incontinence, urgency frequency syndrome, and emptying symptoms. Emptying symptoms, I'm stressing because it's very, very difficult to treat them. This is a typical clinical manifestation. So beside the LUTs, you may have pelvic pain. Beside this, you may have hematuria and stricture disease. This is the incidence of, and when they appear. As you can see here, the very few, at the beginning, they have some issues, some mild urgency and frequency, which develop to really significant levels starting the third month after the treatment. And those are all important information because we should address these patients before they are going to radiation treatment. And I'm not talking only about radiation for prostate cancer. The radiation is done, and in the modern center, we should be developing, we as a functional and reconstructive urologist, we should be developing cancer survivorship program, which should start in talking with our patients before any treatment. That's this should be our new goal in addressing the problems. What is the evaluation for LUTS? Well, same as any OAB. You want to know how bad is the problem, and avoiding that is a great tool to do this. You may use the urodynamic study to study the compliance of the bladder. Combining function with morphology is crucial. You need to see the quality of the tissue that was submitted to radiation. Is there any ischemia already present? Is there any necrosis there? Is there any stricture? And there's nothing better than putting a small camera into the lower urinary tract and assess this. But don't be limited only to the urethra. Check the changes in the skin in the area. I've been reconstructing a lot of penises after generic radiation therapy of the pelvic floor, of the pelvic area for other type of cancers, where the skin became a problem. So you need to use quite some reconstructive skills to address this problem. And of course, the stricture for secondary to radiation. Hematuria is a common problem. Up to 10% of these patients will have some sort of hematuria. Up to 5% they will have severe hematuria. Very difficult to treat. I remember one of the most difficult hematuria to treat is the one after radiation therapy, because it's very difficult to address. You may need to resect, but this may not be enough. Sometimes you need to send your patients to interventional radiologists and to use embolization to address this problem. Sometimes you need to do a diversion because of this, or use additional treatments like hyperbaric treatment. Stricture, it's a big problem in the radiation treatment. It's common. You can have strictures in any part of the lower urinary tract, starting from bladder neck to the tip of the penis or the meatus in the female. Dilation is not working very well in non-radiated urethra. It's not working at all in radiated urethra. You have pretty good success rates with the urethroplasty. So those are something that you need to have in your armamentarium when you are dealing with this type of patients. Sometimes the patient would need directly a stoma, and you should just abandon the idea of if the morbidity is such that he or she cannot survive the surgery. But so this topic is so important that, and this is a subliminal message to my friends from the organizing committee, that this could be a topic for the next meeting that you're going to have, and I'd be more than happy to cover the tips and tricks on how to manage stricture disease in radiation surgically. It's a lot of time to go, so I don't have enough time to cover all of this. Is it possible to prevent the LUTS after radiation treatment? I think we can learn a lot from this study done by nursing. This is like a Japanese nursing group that actually studied the quality of life of patients before and after radiation. And what they found is that our patients, they don't know how to manage. They don't know what they're gonna where they're gonna encounter, what is gonna happen to them after radiation treatment. So they realized that if you can work with your colleagues that are doing radiation treatment and see these patients and tell them, listen, in the first 3 months, you're gonna have some urgency that you may not have before. After the 3rd month, your urgency is gonna be worse. So those are the things that you can do to manage your urgency. Maybe if the urgency is bad, you may have to add some anticholinergics or some beta-3 agonists to improve your symptoms. Maybe you should learn how to empty differently your bladder before getting into this. You see, these are all things that we, in the new era, we should offer to our patients in a comprehensive cancer survivorship program. And one thing that we can learn from the COVID pandemic is that you don't have to see this patient. You don't have to add additional burden on the patient to come to your office. Those are excellent tasks that can be very well performed over web in telemedicine. There are things that you can inject into the patient's bladder, such as hyaluronic acid. This is this Italian group. I think it's interesting. I don't think this works for everybody, but these are some solution for difficult problems. This is a mixture of chondroitin sulfate and hyaluronic acid, kept for at least 1 hour. Just the idea of keeping something in an irradiated bladder for such a long time is challenging, but the results are promising. As you can see here, they all go for emergency, nocturia, urgency frequency, and pain syndrome. They significantly lower the burden of the symptoms. We don't want to cure, we cannot cure them, or we cannot prevent, but we can manage. And this is all our patients are asking us, to listen to them and to know how to prevent and how to manage their bothersome symptoms. So radiation therapy induces complications and are dose dependent. There is a late onset of this, so the patient needs to be aware of this that can occur later. So you have to be with them, you have to be ready, and they should be informed of what can eventually happen and how to prevent. So I hope that I gave some just a rough idea on what radiation can do to our lower urinary tract and how we as urologists should start promoting this idea of cancer survivorship clinic offered broadly, not only to our oncology, urology colleagues, but to everybody who is doing oncology procedures, surgery, radiation, or things like this in the pelvic floor. And I really hope that I will have a chance in your next meeting to go over the surgery and how to manage complications surgically for intractable stricture disease. Thank you very much for having me here again.
Ervin'e bu güzel sunum için çok teşekkür ediyoruz. Ayrıca zamana da çok uydu kendileri. Onun için de ayrıca teşekkür ediyoruz. Soru var ise bir veya iki soru. Ömerciğim buyurun.
Tekrar teşekkürler. Bu inatçı, radyoterapi sonrası inatçı hematürüler için yaklaşımda hiperbarik oksijen veya embolizasyonla ilgili görüşleriniz nelerdir onu merak ediyorum.
Hyperbaric treatment is a great tool. I have quite a big experience with patients after radiation and additional surgeries. For instance, I have a patient who had an AUS implanted, so he had radical prostatectomy, had an AUS implanted, radiation treatment because of the positive margins, AUS implanted, and developed like a couple of years after hematuria. So we scoped him. I was not able to identify a real source of this bleeding, but there was like an area. This is where the balloon was actually impressing, the pressure regulating device was impressing on the urethra, on the bladder. So I tried to coagulate this, I tried to laser the area, it was still coming. Every couple of months he would be coming back with bleeding. Until I decided to send him to hyperbaric treatment, which actually took care of the problem. So if it is like a moderate hematuria, moderate bleeding, hyperbaric is an amazing option if you have it. If you have a severe bleeding, you can try to use embolization. But keep in mind that the more aggressive you are with the embolization, the more side effects on the lower urinary tract you're going to have. If you have like a sphincter, you have one double cuff or things like this, you can actually cause big damages on the urethra.
Sayın Dernek Başkanımızın da bir sorusu vardı.
Mr. President.
Teşekkürler. Aslında Ömer sordu benim sorumu ama benim sorum radikal prostatektomideki radyoterapiye sekonder değil. Onlar bir şekilde idare edebiliyoruz ama kas invaziv olan mesane kanserlerinde, metastatik olmayan olgularda, radikal sistektomi kabul etmeyen hastalarda radyoterapi artı kemoterapi verdiğimiz olgularda hiperbarik oksijenizasyon hiçbir işe yaramıyor. Bunların hiçbiri de işe yaramıyor. Selektif embolizasyon öneriyoruz biz. Sizin bu konudaki düşüncenizi soracaktım. Yani oradaki radyoterapiden farklı bu. Mesane kanseri için yapılan radyoterapide inatçı, çok rahatsız edici gros hematürler oluyor.
Yeah, of course. I never said that embolization and radiation treatment are the same. They're different things. The more aggressive the bleeding, the more aggressive the solution, of course. Embolization is a great option. But I'm just saying that if you have anything implanted into this patient, for instance, a cuff, for instance, an AUS, and you do a very high embolization, so if you're not selective enough, you can cause big problems. You can cause ischemia on that area, so you can cause secondary necrosis and then erosion of these things. So yes, if you have an experienced interventional radiologist, that's the way to go. But it's more invasive than the hyperbaric treatment, but less effective. So it's all about balance. And some of the patients will unfortunately need just a diversion and eventually a cystoprostatectomy.